First of all, good afternoon to the participants. I express my gratitude and thankfulness to the APA, that is Andhra Pradesh Pet Practitioners Association, for giving me this opportunity for presenting the first webinar in the APA Association. So coming to the topic, nowadays we know well the pet parenting or the pets undergoing the pet training or the pet is increasing day by day. The pet population is also increasing day by day, and at the same time the pet parenting also is increasing by day. Whenever we are using or we are adopting a pet, it is becoming like one of the family member. So whenever an issue comes to the particular pet, it will be concerned to the each of every family member. So in the aspects of the pet, they may get the soft tissue conditions and the concerns, orthopedic concerns, or the ophthalmic concerns. And coming to the our veterinary doctors or the veterinary members. So in the present era, at first, we are well aware of the soft tissue, and slowly
ఏదో ఒకటి వెబినార్ ఒకటి వచ్చింది సార్ ఆప్థాల్మాలజీ మీద. యాక్చువల్ గా వెయిట్ చేస్తున్నాను 2 days నుంచి. మీరు పోయిరండి.
Mahesh, 1 minute. Mahesh, please unmute.
Hello. Hello.
Yeah. Now you are audible.
Is it audible now?
Yes.
Hello.
Okay,
Yes,
sir.
Mahesh, you are audible.
Okay,
Sir, yes, you are audible.
Please
So
continue.
coming to the actual topic, that is the general ophthalmic examination in canines. Briefly, if you go in this, mainly I will come across. Slide is not changing. Hello.
Yeah, Mahesh, 1 minute.
Yeah. So here, generally we will come across the introduction part, the basic anatomy of the eye. I will not touch the in-depth of the eye structure. Whatever the thing needed, I will come across in this topic. And the general examination of the eye. In any case, we will get the anamnesis, that is nothing but history collection, and how we will approach through the hands of examination, and then next the hands-on examination, then the take-home points. So if you see the frontal view of a human eye and a canine head, in case of the humans, we generally see a larger white area in the eye. That is nothing but the sclera. And in that, we can see the remaining things like iris, everything. So here, what I want to tell is, in humans, we will see mostly the larger area. Whenever we see the frontal view of the human beings, we will see the sclera, which is a larger area, which will cover the eye. Whereas in case of the canines, we can see here, we can clearly appreciate the iris as a larger area compared to the sclera. A sclera, we will observe a little bit. This is a comparison in between the frontal view, in between the human and the canine eyes. And as far as possible, if you relate it to the vision, generally, if you see, it is having the binocular vision up to 60 degrees, and the uniocular vision 90 degrees, and it have the blind area that is behind, it is about 120 degrees. So the binocular vision is nothing but with the both eyes up to this extent, that is a 60 degrees extent, it can observe other things. Whereas the 90 degrees, it can observe, that is the left eye means on the left side it will observe the uniocular vision, or the right eye means it will observe to the 90 degrees. Whereas the blind area means it is the area which the animal can't see whenever it is in a straight direction. So actually these degrees is related to the mesencephalic animal, that is Labrador or the golden retriever animals. A slight variation will be vary with the breeds, that is depending upon the skull type, that is a dolichocephalic and the brachycephalic. But as this is a thing whenever comes to the vision. And coming to the vision, the other things what we have to notice is coming to the rods and the cones. If you see the canines, in case of the canines, the rods are well developed when compared to the humans. So that's why in even a dim light, they will easily detect the moving objects. Mainly they will observe that they detect the motion and the shape. So even in a dim light, they will clearly observe. But the disadvantage in case of the canines is they lack the color vision, because the cone cells are very, very less present on the retina when compared to the human beings. So they can't differentiate the different colors. Only they can observe the wavelengths of the from the violet to the blue light. So they can observe the blue light. So this is regarding the vision, that is having the modest binocular vision and the larger monocular vision, and the blind area will be up to the 120 degrees, and the cone color perception is very, very less in case of the canines. So then coming to the basic anatomy. So on your frontal view, as I said earlier, we can clearly appreciate the most portion of the eye or the fornix. You will observe the iris. Next, you can observe here in the first picture, you can observe the most portion of the fornix. You're observing the iris. And coming to the different structures, what you will observe on the frontal view, we know well these are the eyelashes and the pupil and the cornea and the conjunctiva. And this is the limbus where the cornea and the sclera will meet. And a red portion we can observe at the medial canthus side, that is nothing but is a third eyelid. So coming to the in-depth, that is mainly it contains three tunics. Those are the fibrous tunic and vascular tunic and the nervous tunic. So the fibrous tunic mainly contains the sclera and the cornea. So the vascular tunic will contain the choroid and the ciliary body iris, and the nervous tunic is contain the retina. So in this, the vascular tunic will give the nourishment to the entire eyeball, whereas you know how the retina, the functional aspects, and the cornea, sclera, or the aqueous humor, they will mainly focus the light on the retina. So coming to we know the cornea and the sclera. The cornea is nothing but it is the black portion of the eye, whereas the white portion of the eyeball is nothing but is the sclera on the frontal view. So if you want to examine the cornea on the pen torch, it is always better to examine an oblique view. Then you can clearly differentiate the corneal surface. And coming to the uvea, generally most of us we can't know what is uvea. Uvea generally contains the choroid, ciliary body, and iris. If you see the choroid, ciliary body, and the iris, so here what are the main functions of these things? Coming to the iris, so here you can see this is the iris. Iris is nothing but it is a shutter like thing which will open and close the lens. So whenever it constricts, it will close the lens, and opens, dilates, it will open the lens, and we can clearly appreciate that. That is, it's nothing but it is a bivalve door, or like a valve like thing. So then coming to the ciliary process or the ciliary body. So generally the ciliary body, it contains the ciliary process. From the ciliary process, you will observe the zonial fibers or the zonular fibers. These are zonial fibers. So what it will do is, the main thing, the zonular fibers will hold the lens. Whenever there is a damage these jonular fibers, the lens will be luxated either posterior or the, depending upon the force, anterior or the posterior, the lens will be luxated. And here the ciliary body, which will contain the ciliary muscles. Here you can appreciate the clearly the thing, the ciliary body. Inside you can appreciate the ciliary muscles, which will responsible for the constriction and the dilatation of the pupil. So the pupil is nothing but it is not a separate structure. It's a, because of the constriction and the dilation, there will be an opening, that is the nothing but the pupil. And here the finger-like projections you can appreciate here. This one from the ciliary body, those are nothing but ciliary process. These ciliary process, from the ciliary process, there will be fiber-like things will be attached to the lens. So these are responsible for holding the lens at the position. So this is regarding the uvea, and the choroid is nothing but it is a covers the entire retina, outer surface of the retina, and it will nourishes the retinal layer. And the last thing, that's a retinal layer, which we can examine as a optic disc or the optic head under fundus examination through the indirect ophthalmoscope. Again, the things, the retina contains the 10 layers, these are all not required. And coming to the, what are the different chambers of the eye? So these chambers mainly contain the fluid, which will maintain the intraocular pressure. So what are the three different chambers means? Anterior chamber, the posterior chamber, and the vitreous chamber. So among these three, the vitreous is the one which has the, which is the largest one. So what is the function of this vitreous means? Is the vitreous is main, it will nourish the entire eyeball, especially the retina, and it also gives the shape of the eyeball. So coming to the anterior chamber and the posterior chamber. So the anterior chamber and the posterior chamber mainly contains the fluid. So coming to what is anterior chamber means, the anterior chamber, it is nothing but the space between the, this is the cornea and this is the iris. So the chamber that is present in between the cornea and the iris is nothing but the anterior chamber. It is the second largest chamber of the eyeball. Whereas the space between the iris and the lens is the posterior chamber, where it also contains the aqueous humor, but the chamber is very, very less space it will occupy. So in both anterior and the posterior chambers, the aqueous humor will be present. They will flow from the anterior to the posterior chambers by the uveoscleral pathway or through the pupil. They will flow from one chamber to the another chamber. So this is regarding the basic anatomy of the eye, which is enough for the general ophthalmic examination. So later, how the fundus we will discuss later while coming to that particular topic. Then coming to the general examination of the eye. So first of all, whenever a case approach, whatever it might be the condition, whenever it approaches to the doctor, we have to get the anamnesis. So that is nothing but history collection. So in the history collection, the general things we will ask, what is the onset and what is the duration of this condition. So when it was appeared, how long it was appeared. That is about whether it is a 2 days or 3 days or 4 days after presentation, before presentation. And then we will also ask about the treatment given, whether any treatment given, and how is it progressed after treatment, whether it is reducing or increasing or is static, we have to ask. And the third one is the change in the diet. It is very, very important. So in my span of the 3 years at the hospital of SVVU SSVH at Visakhapatnam, I have observed 3 cases which are having the allergy, the conjunctivitis causing because of the food allergy. So how they approach it means within they have approached as it is about the 3 cases I'm telling about the food allergy. These 3 cases are presented to us with the conjunctivitis. At the earlier, I thought that it is a normal conjunctivitis, so I prescribed the normal antibiotic eye drops and the steroid. So the other during examination, the other eyeball contains or the eye examination is normal. But after you using these eye drops, they are subsiding. And again, after 10 days, the owner is coming and saying that again they are getting the conjunctivitis. The owner is thinking that whenever we are using the drops, eye drops, the conjunctivitis is reducing. But in doubt, I have asked the owner about the food condition. What are the things you are giving? So what are the things you are giving per week basis? That is once or the twice a week. So he mentioned out of the 3 cases, he mentioned for the 2 dogs, they have given they had given the mutton, and the other dog they have given the liver. So whenever they are giving the mutton for 2 days, they are observing the conjunctivitis and liver also. So I said you stop the mutton and the liver to that particular owner. So then after that, these presentations, the conjunctivitis were reduced. So I said to the owner the same thing. So it is because of the food allergy. So the mutton and the liver, they are the allergic to the particular patients. So this way, the diet, about the diet is also important. And coming to the diabetes mellitus, how it will be whenever you observe a sudden blindness or the sudden opacity of the lenses, you have to ask the owner about as that the animal is having the history of the diabetes mellitus. The diabetes mellitus is nothing but because of the excessive glucose, there will be opacity of the uh, eyes, especially in the lens. How it will happens, you can see on the right side of the screen. Because of the excess glucose which is present at the lens fibers at the cellular level will be converted into the sorbitol because of the aldose reductase enzyme. So it will change the osmotic gradient in the fibers and will cause the swelling of the lens fibers, and we will get the cataract. So in this way, the history or the anamnesis will be useful in the general examination of the eye. So the next step is the hands-off examination. So generally, whenever the case present, you just tell the owner, leave the dog in that particular examination room or the area, and just leash off and make it to run. Then you have to observe, the ophthalmologist should observe the pet behavior, mainly the discomfort. Is it going with the cautious gait? Is it going after sniffing and going? Or is it hitting any objects? Or is it showing the blepharospasms while going? Blepharospasms are nothing but the continuous eyelid movement is known as the blepharospasms. So these things you have to observe whenever the hands of examination after just leaving the pet in a room. So whenever there is a cautious gait, or the animal is eating in objects, or the animal is sniffing and going, means the animal is under it is having the blindness. So again, a thorough examination is needed. What is the reason behind it? They have to go for it. And in some breeds, the dolichocephalic breeds and the Dobermans, it's a common thing, a mucus discharge we will observe at the medial canthus side, if it is a small little bit quantity. Why? Because of the they will have the narrower tear duct canals. So because of the narrow tear ducts, the what you call the patency will be reduced, and it will be again the discharge will be present at the medial canthus side. This is a normal thing, just I want to tell, in the dolichocephalic braids, which we will observe in the Dobermans, which we will examine during generally the Dobermans will be we will get from the police squad especially. So the hands of examination here, whenever you put it in table, we will not hold the dog or the pet. We can see these cases clearly. We can tell, for example, the first image, you can see the traumatic proptosis is nothing but just pouching out of the eyeball from the orbital sockets. These things are generally for the traumatic origin, or sometimes it might be due to the retrobulbar space occupying lesions. So whenever here the history will play a good role. So here in the first case, it is a traumatic proptosis. Mostly as it is a bilateral, it is mostly because of the traumatic origin. Sometimes it may be the space occupying reason in the retrobulbar area. And the cherry, we know it's a common conditions which we will observe in the Shih Tzus or the beagles, we will commonly observe. The cherry is nothing but it's a prolapse of the nictitating glands or the third elite gland. And the third image, it is anisocoria. You can clearly see that the differentiate the pupil size. On the right eye is showing the constriction, whereas the left eye is showing the dilatation. So there is a unequal size of the pupils, which we can use the terminology that is the anisocoria. So after hands-off examination, we have to go for the hands-on examination. So generally the hands-on examination, we have to test the animal and you have to examine the entire eye. So it should be done in a well-light area. So here how to restrain the pet means you have to hold one hand should be under the chin. You can appreciate here. And the other hand should be behind the back of the head. Like this, you have to hold the head. And here examine the eyelashes as well as examine the conjunctiva and just lift the upper eyelid and observe the upper fornix or the upper conjunctiva or the scleral area. At the same time, you have to do the lower eyelid also the same thing you have to do. So here in the normal eyes, generally if you observe, they are the a bright color without any discharge, without any redness, and without of the bulging, we can see, which we can appreciate in the right side of the image. So generally for the hands-on examination, we can use the pen torch, which we commonly use. This pen torch, it has the light source and the switch on, the switch of the button. And some pen torches here having the the cobalt blue light, white light, and the yellow light, which are advanced one. And we can also use the fin of trans illuminator. And we can also use the indirect ophthalmoscope. So where in all these things, they have the light source. So the hands-on examination. So these are some of the examples of which we can notice during the hands-on examination under the light. So here the first image, you can appreciate the entropion in the lower eyelid, and the upper eyelid is also showing the some sort of the entropion. Here how we can see here, you can see the margin of the lower eyelid margin. At the lateral side, you can appreciate the eyelashes. Whereas in the medial side, we can see the inversion towards the globe. That is nothing but the entropion. Whereas here in the second picture, you can appreciate the ectropion at the lower eyelid. We can clearly observe the outward turning of the lower eyelid here. This is nothing but the ectropion. And here, the third image is the dystrichiasis. And the fourth image is the trichiasis. So what is dystrichiasis and the trichiasis? How we have to differentiate means here the dystrichiasis, you can see these dystrichiasis and the trichiasis are the ectopic cilia. These should be, especially these are related to the abnormalities in the eyelashes. So these things you will appreciate. We have to think in case of the cases whenever there is a opacities of the eye. These things we have to observe. In the third image, if you see, there are some eyelashes are protruding from the different location from the actual normal eyelashes. See, you can see these things, the eyelashes, which are from the different locations from the normal eyelashes area. So this condition is known as dystrichiasis. So some eyelashes will appear on the different location from the normal eyelashes position, and they will cause irritation to the eye, especially to the cornea, and they will produce the opacity. This is known as dystrichiasis. Whereas the trichiasis means it is nothing but the what you call the turning or the shape of the eyelashes will be towards the eyeball. So generally the eyelashes should be outside, but the shape and they will turn towards the eyeball and they will cause the irritation to the cornea and they will cause opacity. This is regarding the dystrichiosis and the trichiosis. These things you will mainly need it whenever you observe the opacities of the cornea. These things we have to appreciate. This is regarding some of the things generally we appreciate during the hands-on examination, as well as you have to examine the how the conjunctiva at the lower eye level and the upper eye level also. And coming to the hands-on examinations, generally the vision test, we will first we have to go for the Meniere's response. So what is Meniere's response is nothing but Meniere's is nothing but a response means nothing but it's a threatening gesture we have to give will cause the animal should blink or pull away slightly from that particular threatening response. This is a normal response. If it shows a blinking or just pull away the head means it is showing the Meniere's response positive. And what for it is done is it is to test the visual pathway, that is the optic nerve, and it also checks the facial nerve. So optic nerve is a sensory which we will vision, and the pathway we can see how it will occur the Meniere's response in the coming slides. So whenever you are observing the Meniere's response, you have to close the other eye like this. If you want to examine the right eye, you have to close the left eye and examine the left eye and make a threatening response. So you have to do this threatening response both medially, laterally, and also from up and the down. So why these things are required means in some conditions the opacities may present on the medial side, on the lateral side, or the pigmentary keratitis may block the entire medial side at the lateral side or the upper side, the lower side. So to avoid these false negative things, we have to do the threatening response from the medial, lateral, as well as up and the down. Whenever you are going, it should not provide the air currents, and also it should not touch the eyelashes. So these Meniere's response is absent in the less than 10 to 12 weeks of the old. So the incorrect procedure, this is here the doctor is doing the Meniere's response without closing the other eye. So this is a wrong procedure. Here you can appreciate the correct procedures. One eye should be closed and you have to examine or give the threatening response to the other eye. So this is the correct procedure which we can appreciate in the second and the third images. So if you see the video, you can appreciate here the Meniere's response. He's closed the other eye. Then he's showing giving a threatening response where you can see the blink reflex as well as a slight movement of the eyeball towards inside because of the contraction of the retrobulbar muscles. These things will be observed. So this is known as the Meniere's response. We can appreciate clearly the blink reflex in the video, which is a positive to the Meniere's. So coming to the what is the pathway means. Here, this is a neuro pathway for the Meniere's response. Whenever you give the threatening gesture, it will go the cranial nerve 2, that is nothing but the optic. Then through the optic, it will reach to the brain. It will cross the optic chiasma and reach the brain in the occipital bone where the visual cortex is present. There, the stimulus will be generated, and again the stimulus will reach to the motor sensor or the motor cortex. From the motor cortex, again the reflex will lead to the cerebellum, the pons region. From the pons, it will give to the what you call the cranial nerve. That is the facial nerve, which we can appreciate the facial nerve. From the facial nerve, it will cause contraction of the orbicularis oculi muscle. So then the orbicularis oculi muscle will contract and it will show the closure of the eyelid whenever you show the Meniere's, whenever you show the threatening gesture or the threatening thing. So the same thing you can appreciate in the second video also. It's a anatomy. Whenever you're giving the micro, or whenever you are giving a threatening gesture, the optic nerve will respond. and from there it's a sensory thing, optic nerve. So it will reach the brain, again it will reach the vision cortex. From the vision cortex again it reaches to the motor end. From the motor end to the facial nerve, which is a motor one, and it will reach the orbicular ocular muscle, which will show the contraction. So if the eyelid is not contracting, it indicates the menace negative. This is regarding the menace response. So menace response is nothing but whenever the giving the threatening response, the blinking or pulling the head away from the threatening gesture is known as menace response positive. If you're not observing that reflexes, it is a negative. So then the pupillary light reflex, the PLR, it should be done in the normal room light as well as in the dark light. So here the mainly we will assess the retina, optic nerve, and other pathway functions. So what we have to do means, here you just apply a bright light to the eye. Generally to the bright light, the pupil should constrict, which is known as the direct reflex. If you focus on the one eye, the focusing eye, if it shows the constriction, it is called direct reflex. If you observe the other unfocused eye, if it is showing the constriction of the pupil, it is known as the indirect reflex or the consensual reflex, which is also a normal. So this is known as the pupillary light reflex. In this, generally what are the nerves involved? The optic nerve, which is a sensory, and the motor here, the oculomotor nerve will be involved, where the iris muscles from the oculomotor, the iris muscles will act after getting a light reflex. Then it will cause the constriction whenever the bright light is exposed. It will cause the constriction of the pupil. Whenever it will get the dim light, the pupil will dilate because of the relaxation of this iris. And this is regarding the what is the pathway of the pupillary light reflex. Here mainly the optic and the oculomotor nerves mainly involved. This is a neuro-ophthalmology, is again a different chapter which will take about 1 to 2 hours. So coming to the different eye reflexes, you can appreciate clearly here in this video the different eye reflexes, the menace as well as the positive things and the negative things, menace as well as the PLR. So here the examiner is observing under retroillumination. Here you can see the retroillumination, you can see the tapetal reflex here. See, whenever he is observed a small window, you can appreciate the tapetal reflex, you can clearly observe both the eyes were dilated. And coming to the hands-on examination, see the pupil is constricting whenever a bright light is focused. At the same time, if you observe on the other eye also, it is constricting. So it is the direct reflex. It is showing the PLR is positive at this particular condition. And at the same time, you have to observe the redness on the upper scleral position as well as lower scleral position. She is now observing the menace response. The menace response here, the menace response, she is closing the one eye, and the menace response is positive in both eyes. So some abnormal conditions here. It's a 6-year-old German Shepherd, male castrated. So you can clearly observe the tapetal reflex on the right eye, and also you can observe the anisocoria. Here you can appreciate the the dilatation. Whenever a bright light is focused here, you can see here you can see clear whenever the bright light is focused, it is not constricting. So it is some abnormality. That is PLR negative. The direct reflex is negative. And even the menace reflex is also negative in that particular eye. So you can see the clear dilatation of the both eyes. Later, they have concluded with the fundus examination, some lesion in the retina. This is regarding the one case. And the other case, it's a 7-year-old, which is have the progress of vision implant. On retroillumination, you can clearly observe the mydriasis for the brightness. It should not be present in both the eyes. So here you can see that there is no constriction in both the eyes. Here, after fundus examination, they got because of the tapetal hyperreflectivity on the right eye, which is an abnormality in the retinal thing, and the other thing on the left eye, they have observed the cataract. This is regarding the reflexes, the Meniere's response and the PLR. These two things are main responses which we can use in the general ophthalmic examination. So then the maze test or the obstacle test, where you have to place the animal in an unfamiliar room, and the owner should be on one side, and the objects like dustbins like this in the image, you have to keep it. The dog should be on the other side. The owner should call the animal. It should, without hitting the object, it should come. If it comes means the dog comes means it's a normal vision. If it hits the objects and sniffing and coming means it is having, dog is having the vision, something abnormal in the vision. So these are the some of the neuro-ophthalmic reflexes. What are the nerves involved? The PLR, Meniere's response, basal, palpebral, and the corneal. So the PLR and the Meniere's generally commonly we observe in the general ophthalmic examination. So coming to the other things, what we can do is the first thing we have to do after hands-on examination is the Schirmer tear test. Here what the Schirmer tear test is nothing but here the tear production we will measure. So for this production measuring of the tears, we need a Schirmer tear test strips. So this is the package will be available. In this strip here, the 100 strips will be available. If you see the strip, you can see a notch at the proximal end of the strip. And also you can see a bright blue color at the proximal end of that. So whenever you place it on the lower fornix, you can appreciate the wetness like this. This is the strip after placing the Schirmer tear test, Schirmer strip into the lower fornix. So here how we have to measure. Here you can clearly appreciate the blue color is approximately staining up to the 17 mm. This is the thing you will appreciate after keeping the strip in the lower fornix. So generally what is the placement we have to keep is means it is generally in the lower eyelid, that too in between the middle and the lateral third of the lower eyelid. So why we have to place at this particular position means here it will touch the conjunctiva as well as the cornea. So because of this, we have to place this strip at that particular area. So later we can see what are the do's and the don'ts whenever you are going for this Schirmer tear test. I think it is audible. Hello?
Yes, sir, audible.
So coming to the Schirmer tear test, that is a STT1 and the STT2. So STT1 is generally what we practice in the veterinary field, which is having the diagnostic value. Whereas the STT2 and the STT3 will be used in case of the humans and the humans. Here in the veterinary field, STT1, we will commonly call it as Schirmer tear test, STT. So what is a Schirmer tear test 2 means? It will mainly measure the basal and the reflex tear production. So what is the basal means? Basal meaning here means here what is the quantity of the tear producing because of the keeping of this particular strip, or the normal tear production from the particular lacrimal glands. So and also it will measure the reflex tear production. The reflex means here whenever you apply a strip to the lower fornix, the cornea will be irritated and it will give a reflex by producing some quantity of the tear. That is known as the basal and the reflex tear production. So whereas in case of the STT2, it will only measure the basal tear production. So other differences are here in the STT1 directly we will place the STT strip without any ocular surface anesthesia. Whereas in STT2, we will use the ocular surface anesthesia. Here, generally we will use for the ocular surface anesthesia, we can use the proparacaine, 1% proparacaine we can use for getting the ocular surface anesthesia. So, and the STT1 is a diagnostic value. So generally after placing this strip, you have to wait for the 1 minute. Then you have to observe the how much distance the staining has occurred on the strip. So here, if you appreciate here, the staining we can appreciate up to the 17. So what are the normal conditions? We'll observe in between the 15 to 25 mm per minute. It's a normal one. If it is a borderline, that means in the 10 to 15 minutes, it's about to getting the cases of the dry eye. If it is less than 10 mm per minute, it is obviously the keratoconjunctivitis, Sika. And the ST2, generally the normal values are half the values of the SST1, but the STT2 is half the diagnostic value in case of the humans. So what are the do's and the don'ts? One is the do's is you have to fold the notch before opening the cover. That means the strip should be, whenever the strip is present within the cover, you have to fold that notch, because it will avoid the contamination of that particular strip. And the correct placement, I had already given the correct placement where you have to put, and what is the reason why we are placing at that particular position also. And you have to always partially open the palpebral fissure. And what are the don'ts? Don't do for the excessive manipulation, and the hand should not be wet or the greasy, which will cause some disturbance in the strain. And coming to the next one is that is the external stain. You can use the fluorescent dye as well as the rose bengal dye. So here the fluorescent dye, generally the strips will be available like this. So which will have the orange dye at the one end, and the rose bengal dye, it will have the dark red color on the at the end. So these dyes, what is the principle behind this means? The dye is the hydrophilic. So whenever the wet, it will get moist, it will get the color. That means hydrophilic means the water loving. Whenever the strip is placed in the water, then it will get the color. That is obviously this is will be green color. So here, how we have to place these dyes? We can use as a strip, or you can use also in the other way, I will tell you. So whenever you are using the strip means it should apply to the conjunctival area or the dorsal sclera. For this, you have to just apply a normal saline to the strip, then just lift the dorsal, that is the upper lip, so that we can appreciate the dorsal sclera like this. Then the normal saline applied strip should be just paint over the sclera, the dorsal sclera. Then just close the eyelid, then observe for any pathogenesis, that is the ulcers. And the second way is you can cut at the orange dye up to here and take it in your syringe, then take a normal saline into that. It will give a orange, a greenish color dye color. We can put it like a drops in the eye for examination of the corneal ulcers. The other thing is we need a cobalt blue light also for observing the fluorescent dye. So why the cobalt blue is required means generally the fluorescent dye will flourish in the cobalt blue. So what is the principle behind this? You can get it here. That is some molecular white will occur. So we can appreciate a different corneal ulcers. If an expert, we can clearly appreciate different things whenever you stain. The superficial corneal ulcers, deep stromal ulcers, and the descemetocele and indolent ulcers. So what is the specific characters of whenever you observe a superficial corneal ulcer means? So here generally the ulcers, as I said, in the cotton blue light, it will flourish as a apple green like this. So here in the superficial corneal ulcer, you can clearly observe the clear-cut margins of the corneal ulcer. Here has a distinct margins, and also we can appreciate the floor of the stained part, that is the ulcer. So this is regarding the superficial ulcer. Whereas in case of the deep stromal ulcer, here the deep stromal ulcer means here the fluorescein will spread to the margins, as well as it will diffuse from the margins like this. This is spreading as well as to the floor. Here you can clearly see in a depth like thing here, and also the margins are not clear as the superficial ulcer. Here you can clearly notice the diffusion of the dye from the margins towards the eyeball and also towards the floor. This is the difference between the superficial and the deep corneal ulcers. And coming to the next one, descemetocele. So descemetocele is nothing but, we know well, the different layers are present in the cornea. Mainly the 5 layers, that is the superficial epithelium, Bowman's epithelium or the basement, and the third one is the stroma, and the fourth one is the Descemet's membrane, and the fifth one is the endothelium. Here the descemetocele means whenever the ulcer is reached up to the Descemet's membrane, the Descemet membranes will come through the ulcer. That is the descemetocele. That is a descemetocele is nothing but herniation like thing. Generally, we will use the suffix cele whenever there is a herniation. The same thing, the Descemet membrane will be expressed here. So here you can see the clearly the edges. You can appreciate the dye apple green color, and also you can observe the stroma is also with the green color, because here this stroma and the edges will have the water. The stroma will have the water, so it will take the white, the dye, and it is flourishing in the cotton blue light as a green color. Whereas the Descemet's membrane, which will not have the water, is a hydrophobic layer. So as it is not containing the water, the Descemet membrane here is not getting or not taking the dye. So this is a clear picture of the descemetocele. Whereas coming to the indolent ulcer, here you can see the clear margins. We can't appreciate the clear margins. And also we can see the thin fibers as well as diffusion of the fluorescein dye, which is indistinct. So generally this one you will observe the indolent ulcer. So then what is the indolent ulcer? So indolent ulcer is nothing but it is a spontaneous chronic corneal epithelial defect. So that means it's a chronic corneal ulcer which will not heal normally. So that is the differentiation of the different ulcers whenever you go for the fluorescein dye. So the next one is very, very important. Whenever there is a perforation, complete full thickness perforation of the cornea, you have to go for the Seidel test. It's nothing but whenever you apply a dye, you will generally observe the leakness of the leakage of the aqueous humor from the perforation. I will show the video how it will appear. But as a picture here, you can appreciate the black color here. The black color is nothing but here the aqueous humor is flowing and diluting the dye. So that's why it is appearing the black color. This one you can clearly observe in the side video. And here the greenish green color at the edges, you can appreciate the greenish color. Those are the margins. So this is a video where the perforation is complete. Here cobalt blue application, the dye they are applying. See here the blackness here observing, that is nothing but the aqueous humor is leakaging from the perforation. So it is diluting the dye. So here the brown thing is the application of the dye strip. Whenever you are applying, you are observing the green color, later it is diluting and giving a black color because of the leakage of the aqueous humor, which is diluting the dye and giving a black color. This is related to the corneal perforation, which is known as commonly the Seidel test. You can understand the why the blackness here in the photo can appreciate. It is because of the dilution of the aqueous humor, dilution of the dye because of the leakage of the aqueous humor from the perforation. This is regarding the Seidel test. Then coming to the next one, that is the Jones test, which is required to diagnose the patency of the nasolacrimal duct. So generally how these cases will we get is whenever the constant mucoid discharges present at the both the eyes at the medial canthus side, or discharges might be at one eye at the medial canthus. So whenever there is a patency is not there in the nasolacrimal duct, we will observe these things, that is constant persistence of the mucoid discharges at the medial canthus level. And also because of this improper drainage also will observe in the speeds a constant blackening at the lower eyelid. Staining will be observed at the lower eyelid, especially at the medial canthus side. This is because of the improper drainage. So how we have to go for the Jones test? Whenever after application of the fluorescein dye as a drop wise or with the strip, within 5 to 10 minutes, we have to appreciate the dye within the ipsilateral nostril. So here in the first image, the dye was applied to the left eye, and after 5 to 10 minutes in the cotton blue, we can appreciate the dye at the ipsilateral nostril. That means it's a Jones test positive. That means that side, the nasolacrimal duct is patent. In rare cases, you will observe the dye within the mouth also, which is because of the posterior nasolacrimal duct is opening to the nasopharynx. I haven't observed this one, the second image in the mouth, but I have appreciated this one whenever there is a patency is there. So whenever there is obstruction is present in the nasolacrimal duct, within 5 to 10 minutes, you will not observe the dye at the ipsilateral nostril. So here this is regarding the Jones test, which we will generally conduct for the patency, to check the patency of the nasolacrimal duct. So the next staining, rose bengal staining. So this is less commonly used. We will use it whenever in case of the cats, it will generally whenever you apply these strips or this dye to the eye, generally the dead or the devitalized epithelium will appear like a bright magnetic color. Here you can appreciate is the bright magnetic color. Here you can appreciate. So that means whenever the ulcers in the initial stages, we can use this stain. But because of the reaction of the rose bengal stain, it is less importance in our general ophthalmic examination. Here, in case of the cats, we can, whenever the herpes virus, whenever the eye lesions in the cat, we can go for this staining, and we can appreciate the bright magnetic color, which will indicate the herpes virus keratitis because of the devitalized epithelium on the cornea. So next one is the tonometry. Here tonometry is nothing but measuring of some pressure. So here we will measure the intraocular pressure. So what is intraocular pressure is nothing but it is the pressures of the fluids that are present in the eyeball. So here generally the aqueous humor, which will have the pressure. So the intraocular pressure is nothing but is the pressure of the fluid of the eyeball, that is nothing but the aqueous humor. So how we can measure this means by using the Shear's tonometry, or we can use the tonopen, or we can use the rebound tonometry. So we can see each and everything slowly. So in the old days, the Shear's tonometry is the earlier old days. The Shear's tonometry is in practice. And also in veterinary practice, very, very difficult to use the Shear's tonometry, because as the animals, they're not a good things to go for this Shear's tonometry. Okay, so why it is very difficult means we have to position the animal like this. Here the animal should be placed like the uplift the head, and you have to place exactly perpendicular the Shear's tonometer to the eyeball. So which is very, very difficult in our patients. So as an advancement, now we are getting the tonopen, and The latest one is the Tonometry, is a rebound tonometry. Here coming to the Shears tonometry, here generally it will have the different parts, and also we will keep the weights here. So you can appreciate the foot plate. This is the test block. So this on the test block, after applying the weight, you have to, the weights generally their weights will be present 5.5, 7.5, 10 grams, and 15 grams. These weights will be present. First, we have to put it with the 5-point weight will be placed here on the plunger, and this is a holder, and this is a barrel, and this is the foot plate. So this foot plate, you have to place it on the test block. Okay, like this, you have to place it. Then without moving the foot plate, it will show some reading. So this can be observed by this video. We can clearly appreciate this one.
This is your tonometer.
So this is a Shears tonometer. He is explaining how first what we have to do. So first we have to remove the plunger, open it like this, and clean it with the available thing in that particular box. So we have to clean the plunger area like this, then clean it, because any dust particle will cause inappropriate measurement. So first he removed the plunger and kept it and placed the plunger in the position. Then he kept the 5.5 weight. This is the 5.5 weight what he kept here. So this is the reader which you have to keep on the observer side. He is placing on the test block, and with the holder like this, the holder, you have to keep it the foot plate on the, see here, you can clearly appreciate the foot plate. Here he is just push the foot plate, but you should not do like that. Just for the getting the thing, he just pushed that foot plate. It will show some reading. That reading you have to see, and then you have to check it. For example, if it is getting a 3 value or the 5 value, you have to observe it in a separate, as it is a 5.5 centimeter, he got a 3.5 reading. So the conversion table, it got a 22.4. Whereas if it gets a 6 reading, the conversion table, you have to keep it, and you have to check the what is the measure IOP it is showing in the conversion table. So thereby we have to measure. So then the other doubt is when you have to place the weights. Suppose if you place a 5.5 weight at the plunger, and if you got a reading of less than 3 mm or equal to 3 mm, then you have to increase the next weight, that is 7.5. Then after placing it, the same procedure is followed. Then you have to observe the readings, the corresponding. For example, as we have placed here, they have placed at the 10, and the corresponding value you have to observe in the conversion table. Thereby we can measure the intraocular pressure in case of the Shears tonometry. So this is regarding the Shears tonometry. That is nothing but indentation tonometry. So before going to this procedure, actually before measuring, we have to give the surface anesthesia by using a proparacaine, that is which will give a surface anesthesia. After putting a drop, we have to go for the measuring of the IOP. So the next one is the applanation tonometry, which is an advancement in measuring the IOP measurement. That is a tonopen wet. So these are the covers, blue cover, how we have to place. So it should not be placed like this. It is a too loose one, and it should not be too tight like this. And what is the correct placement means? It is a correct placement. It should snugly fit the tip of the pen. And the right side picture, extreme right side, you can see the how we will measure. So these are the some of the parts of this one, the battery, the LCD display where it will show the pressure, and this is the activation button. It will be blue color, the black color, depending upon the model or the depending upon the company. And this is the tip of the toner pen. So here, before going to the usage of the toner pen, you have to calibrate every day. You have to calibrate it. For example, here the calibration, how we have to calibrate, I will show you here. This is the calibration. So here, the calibration in this video, you can clearly observe the calibration. So he hold the blue button, that is the activation button. It will give the 5 beeps and give the position word that down. You have to keep it down like this. Then it will show the indication of the up. See here, it is showing the up. Then place it slowly on the upside. Then it will give indication the pass. So the pass means the animal, you can use the toner pen clearly. In sometimes, even after calibration, we will not get the pass thing. For example, you can see here the fail, like that thing you will observe in some, whenever the toner pen is not calibrated. In those conditions, the things required is you have to clean it with the antiseptic or the strips, the tips, and also you have to check the battery. This is regarding the calibration of the toner pen. So then how we have to check this on the animal? So this is regarding the how we have to.
Today we're going to be performing a tonometry on her. We have a few pieces of equipment. Can you
This is
see
the toner pen measurement, and
we've got our Riker toner pen, and we have a cane for her. I'm going to go ahead and
so
start.
she is applying the surface anesthesia. Proparacaine generally we will use. Just apply 1 or 2 drops into the both eyes within 30 to 30 seconds to 1 minute. In 30 to 1 second, you will get the surface anesthesia. 30 seconds to 1 minute. And both the eyeballs, she applied the topical anesthesia, that is the surface anesthesia. Then she is placing, after calibration, she is applying the toner pen. So before application of the toner pen, how we have to apply the cap also is very, very important to avoid the mismeasurement or to avoid the contamination. How we have to apply the cap. So cut at the blue side area like this.
I can't touch the white.
So cut on the blue side and keep it on the toner pen like this. Then just remove the cap and just flap it down the cover on the other area. So that is the how we have to place the cover. It is also very important. Then you have to place the toner pen at the 6 times. At each time you're getting a small beep. You can hear here. That beep means, that short beep means it is getting some reading. So whenever you get a short beep, so here you can appreciate here in the video.
And what this is going to do,
See, she's touching.
this is going to give me an average of all the readings.
See, that is a beep. So that means like that you have to appreciate the 6 beeps. That means it has taken the 6 beeps. At last it will give the average of that in the reading. There after the 6 beeps, it will give the reading. That is the average of the all 6 readings. That is the intraocular pressure. So generally there will be variation of the 5%. This is regarding the toner pen. So what we should not do during the intraocular pressure management. So excessive manipulation should not be done, and we should not press the head also. That is the main things we should not do whenever going for the IOP measurement. The next one is the tonometry by using the rebound tonometer. So this device generally will work on the rebound rebound thing. So generally a probe will come and it will touch the cornea. So here the speed at which the probe will be decelerate will directly proportional to the IOP. So this is regarding the parts of the different different parts of this rebound tonometer. So here this is the column where we will place the probe, and here the display will be present. Here the measurement button will be there, the black or the blue. Here you can see the black color, and this is a grip where you have to hold, and this is a battery compartment. So for the rebound tonometer, for the usage, there is no need of the surface anesthesia. But if it requires, generally in our Indian scenario, it requires the surface anesthesia. So this is a video where you can see how they are doing the rebound tonometer. So this is a proper head restraint. So no pressure applied on the rack, like this. Then you can appreciate this is the probe, this is the white one, and the finger should be placed at the orbital rim, which we can appreciate as a bright light. And the probe should be contact at the 4 to 8 mm distance. It should contact perpendicularly. So that is the activation thing. So how this is the holding of the instrument. See how it is touching. So after getting the 6 touches, it will beep and it will give a reading. Here it is the 14 mm edge. So the probe will come and it will decelerate and it will give the pressure on the calibrate. So what should not be done during the IOP measurement? These are the what not to do during the measurement. Improper head restraint, you are applying here, they are applying the pressure on the neck. So it should not be done. And also they are applying pressure on the eyelids. That means whenever you apply the pressure on the eyelids, it will cause automatically the pressure on the globe. And here the instrument, they are shaking. So these things we should not do whenever you're going for the application of this rebound tonometer. So the next one is the ophthalmoscopy. In general, I use the indirect ophthalmoscope for fundus examination. I'm not well versed with the direct ophthalmoscope. So indirect ophthalmoscope, generally it will contain the edges knobs will be present for the height as well as the side, the ears. These are the adjustable knobs. And also it has the brightness control knob, which will decrease or the increase of the brightness depending upon the condition or depending upon the observer. And also it have the different filters. Generally they have the yellow light, white light, and the cobalt blue light, we can see. And this is the front window through which we can appreciate the patient. And we can also, this is a mirror angle, whether it should be placed depending upon the eyes of the observer. And this is the aperture selection lever. That means the filters we can adjust. And the other knobs that are head edges are those things. So after keeping an adjustment, keeping on your head, a 20 diopter or the 20 to 30 diopter convex lens should be placed. Then only we can observe the fundus in the eyeball. So before examination, we have to give the tropicamide, which will dilate the pupil. So then only you can appreciate the clear fundus. So we have to apply the tropicamide, which is a vasodilator. Here you should not use the hometropin, which is a longer duration. It will cause vasodilatation, which will again cause accommodation problems whenever you apply the hometropin. So that's why you should not use the hometropin as a pupil dilator whenever you're going for the indirect ophthalmoscope. So this is a video by using the fin-off transom illuminator, how you can observe. This is the positioning, what distance, that is the full arm distance you have to observe.
To perform
She has
indirect
used the
ophthalmoscopy,
20
you will
diopter
use one of the following lenses that
lens,
are
as well as
a
she has
28
used
diopter,
the
a 20 diopter, or a 2.
FINOF illuminator. So these are the different. So this is a FINOF trans illuminator, the full arm distance, and after getting focusing the eye in the same pathway, slowly introduce the convex 20 diopter lens. Then you can appreciate the fundus. So that is the positioning, how much distance we have to keep. It will also vary with the person to person. After focusing on the light, you have to slowly introduce the 20 diopter convex lens. So generally we will appreciate this is the fundus, the temporal and the nasal area. We will appreciate the highly reflective areas as well as non-reflective areas. Here, if you're coming to the fundus examination, generally we will get generally we will observe the highly reflective area, which is known as the tapetal. This is a typical canine fundus. Here you can see highly reflective area. This is the tapetal fundus, whereas is a non-reflective area, which is the non-tapetal fundic area. So generally, this is a optic head or the optic disc. So it will be present at the junction of this highly reflective area, that is the tapetal fundus and the non-tapetal fundus. Generally in canines, it will be present at the junction. And these are the retinal blood vessels. The retinal blood vessels generally they will be present the superior one. This is the superior one, and the ventrodorsal and the ventrolateral, and as well as you can see the ventromedial blood vessels. So here in the canine, generally these reflective, that is the tapetal fundic area, it should be gold, bright greenish or the yellowish color. That is a normal one. And the non-tapetal fundic area, it should be brownish color, dark brown to the black area. And the optic disc, it should be a white to pink color. This is a normal canine fundus in case of the indirect ophthalmoscope, or the whenever you are using FINOF trans illuminator and using the 20 diopter or the 30 diopter convex lens. So this is the how he is examining.
Here I'd like to give you a sense of what you can.
So after dilatation in both the eyes, after application of the tropicamide, so after focusing into the eye with the indirect ophthalmoscope, slowly introduce this one, the convex probe. Here now you can appreciate clearly the fundic area. Here it is a yellow color, and the black, that is a non-tapetal area. And here in the right eye, we can clearly observe the head also, optic disc also, which is having the blood vessels. That's a white to pink color, the optic head, which we can observe clearly in the right side. Highly reflective area, that is a tapetal fundus, and this is the dark area, which is a non-tapetal fundus. At the junction, you can observe clearly the optic disc. This is a general ophthalmic examination of the fundus using the indirect ophthalmoscope. So this is the flow of the general ophthalmic examination whenever you go for any eye problems. First, you have to go for the anamnesis, then we have to go for the anamnesis. After just take it in a normal bright well lighted room, then gross examination without anything, and on table with using the pen torch or the other illuminators like a direct ophthalmoscope illuminator. Then you have to check for the minis and the PLRs, which we have to use commonly. Then you have to use the STT, that is a Schirmer tear test. Then you have to go for the cytology. If you have any doubt regarding the ABST, if you want to go for, and also if you want to go for the culturing, you have to take the cytology before applying any drops, that is staining or tropicamide. You have to go for the cytology before going for the staining or any application of the other drops. Why? Because these drops of the dyes will cause some reaction to the particular to the eyeball. And then corneal staining, you have to go for the tonometry. Then using the indirect ophthalmoscope or the direct ophthalmoscope, you can go for the fundus examination. So what are the take home points is anamnesis is very, very important. I don't completely rely on the anamnesis, especially in the food allergies. I have explained how I got 2 to 3 cases. We had ruled out that conjunctivitis in that particular 3 cases because of the food allergy to the mutton and the liver. And the menace response, generally it's a vision test. The menace is the main thing, optic and the facial nerve. There is a PLR, it is oculomotor and the optic nerve. And the STT for the dry eye. The corneal staining, commonly we will use the fluorescent dye. And the Seidel test for the full thickness corneal perforation. And the tonometry for the measurement of the indirect ophthalmoscopy. And ophthalmoscope, indirect ophthalmoscope or the direct ophthalmoscope for the fundus examination. So this is regarding the take home points. So for the other special diagnostic techniques, whenever there is a lens relaxation, we can use ultrasonography, and also the retinal detachment, the advancement, retinal, you can use the advanced techniques like ultrasonography, the B mode ultrasonography, which is very, very useful. And the retinography, where the electrical impulses will be passed through the retina by a special procedure. Those are the advancement, but in a general we can it is enough. And the other CT for getting diagnosed the retrobulbar space occupying lesions in the retrobulbar area, CT we can use. And the fluorescent angiography can also be used in the advanced conditions related to the retinal blood vessel abnormalities. So those are the advancements. Still we have to approach there. Still this is the thing generally what we do in the general ophthalmic examination. So here the basic things what we required is a simple pen torch. The stains strips will be available, and also indirect ophthalmoscope, hardly it will cost 10,000, 15,000. It's enough. And but the 20 diopter lens, it will cost more. It will be 10,000 to 20,000. And the tono pens, which will be around 65 to 65,000 to 1 lakh. But the rebound tonometer, it will be very costly. It will be more than 1 lakh. So quite expensive, but if you go on doing these things, we can also enter in depth of the ophthalmic examination, and we can elicit different, we can diagnose different ophthalmic conditions. So thank you for the participants, and also thank you to the APA team for giving this opportunity for presenting the first webinar in the that is on the Practice Association. Thank you.
Thank you.
Thank you,
Thank you.
Dr.
Thank you, sir.
Dr. Mahesh. So if any questions are there, we can please have a chat or a Q&A session. Chat level. So participants, if you have any questions, you can please raise your hand, or you can even post in the chat. So in the chat, I don't see any questions. So
if anyone is having the doubts regarding this general ophthalmic examination, you can post a message in the APA chat, WhatsApp chat. I will directly message to that particular number, directly message to the WhatsApp number. Sai, okay, is it okay?
Yeah, is that? Wait, we have one thing I question. Very good session. Okay, we're getting some applauses. So okay, that's all. I think I don't see any questions in the chat. So with that, thank you very much, Dr. Mahesh. So that's a detailed and lecture with a deep insight into the practical handling and approach in doing a complete clinical examination of eye. Those cases which are suffering with conditions. Hello, Dr. Nagin.
Star number ఏమైనా ఇస్తారా సార్ ఏమైనా వాట్సాప్
Yeah, it is available in the APA team.
APA group ఉన్నారండి మీరు?
లేదు సార్
Then you can play. So you're from, sir? You're from which place?
తెలంగాణ సార్.
Okay. So Mahesh.
9542566016. Just ping, put a message to this
95?
number. That's a WhatsApp thing.
95?
9542.
One minute, sir. 1 minute.
95.
We are just posting his number in the group. And see 1 minute. So 95425 66016, sir. So we just posted in our chat. So those who are from other places, you can just take his number from the chat and DM him directly if there are any questions.
ఇంట్రాక్యులర్ ప్రెజర్ అసలు ఏ సిచ్యువేషన్ లో మనం చూడాల్సి వస్తుంది సార్? ఐఓపి
Sir.
ఐఓపి మనం ఏ సిమ్టమాటిక్ కండిషన్స్ లో చూడాల్సి వస్తుంది అసలు? అంటే ఫీల్డ్ లెవెల్లో మనకి ఎగ్జామినేషన్స్ ఇది ఉండదు కదా సార్, మనకి ఇండైరెక్ట్ ఆప్థాల్మోస్కోపీ కానీ టోనోపెన్ కానీ ఉండదు కదా.
Generally we will observe the bulging of the eyeball, as well as whenever you are observing the blood vessels on the sclera, they will be distended. Whenever you lift the upper eyelid, you can see the episcleral reddening. And also the animal is showing the frequent blepharospasms. In those conditions, we have to go for the measuring of the IOP. So here the instrument is required, then only we can measure the eyeball. So whenever the advancement is there, the cost will be there.
Sir, any more questions, sir? We are happy to answer for that.
ఈ డై ఫ్లోరసెంట్ డై ఒకటి, ఈ ఎస్టిటీస్ మనకి మార్కెట్ లో నార్మల్ హ్యూమన్
Yeah, it is
ఆప్థాల్మాలజీలో
available. You can check in your Amazon or Flipkart. It will be available even in the medical shops that is nearby the ophthalmology centers or the hospitals. It will be available. Well available there.
నెక్స్ట్
Sir, I
టియర్
think,
స్టెయిన్ ఫామ్ అవుతుంది సార్. జనరల్ గా స్పిడ్జీ డాగ్స్ కి, ఈ నార్మల్ గా ఈ మన స్పిడ్జీకి ఒకదానికి పొమరేజియన్ కి మోస్ట్లీ టియర్ స్టెయిన్స్ ఎక్కువ ఫామ్ అవుతుంటాయి కదా సార్.
Yeah,
అప్పుడు
that is,
మనము
please.
అప్పుడు మనము ఇది చూడొచ్చా సార్, ఈ మన నాసోలాక్రిమల్ డక్ట్ ఇది చేసి?
Yeah, that is Jones test. That is the fluorescein dye test. So what will happens means, whenever you apply the fluorescein dye into the eye, because of the lack of patency, the tear will not go through the duct and it will not reach to the nasal puncta, nasal area. So that's why in those cases or the spidge cases, the drops will drain outside, and because of the porphyrins, they will stain the hair below the eyelids at the medial canthus level in a brown color or the black color. It will dyed. So it indicates there is an obstruction in the nasolacrimal duct, so which we can appreciate by this dye. So after applying this dye, you have to wait for 5 to 10 minutes. If you are not observing any dye at the ipsilateral nostril, for example, if you are putting the dye in the left eye, you should appreciate it in the left nostril only, or you can appreciate in the mouth also. Rarely it will see in the mouth. If you are not observing that dye, it is diagnosed as a nasolacrimal duct obstruction. Is it clear, doctor? So
Okay,
in those conditions, we can use the antibiotic steroid drops. It will, most of the conditions it will clear, but the thing is the owners will not clean the eye of the pet regularly. That is the main thing. After getting any discharge at the medial canthus level, first you have to clean regularly. Whenever the pet owners should do that, then only we can appreciate a clear drainage of the TS.
చేయాలి సార్?
Hello.
ఎట్లా క్లియర్ చేయాలి సార్ నాసోలాక్రిమల్ డక్ట్ ట్రీట్మెంట్?
So the treatment protocol is the first one is we have to use the antibiotic and steroid drops, so that most of the 50 to 60% will clear the drainage of the nasolacrimal duct. Still, if there is any problem, you can place the blunt needles after anesthetizing the particular animal, then flush it with the special what you call the IV 24 gauge probes will be available. You can place it in the puncta and instill the nasal drops. If still you are not getting any nasal drainage of the tear, means you have to go for the contrast, which again it will be a great difficult thing. You have to go for the contrast technique. Then you can notice any abnormalities in the nasolacrimal duct.
So in case of any obstruction, what is the next procedure, doctor?
So the next procedure is you have to open the nasolacrimal duct and you have to clear the obstruction. But it is very, very difficult, or I haven't seen any those things.
So Dr. Nagin sir, I think your question was answered. Are any more questions, sir? I think no. So we have one more questions from Dr. P.V. Reddy. So, sir, is there any chance if any keratolytic changes in one eye will affect on other eye which is healthy?
The keratitis, again, it depends upon the infectious origin. If it is infectious origin, may it is not because of the optic pathway, but it is because of the contamination through the eyes or contamination through the eyelashes or the hair on the animal. It may reach to the other eye, but through the optic pathway, or it will not reach, but the systemic through the blood, it may reach to the other eye also, the keratitis, especially in case of the infectious keratitis.
I think those are all the questions. So just so this I think this lecture is provided a realistic experience with such a very crystal clear illustrations and videos, Dr. Mahesh. I think there is one more question just now raised. Please explain treatment for desmotocele.
So the desmotocele, you have to go for the general anesthesia. Then you have to go for the conjunctival pedicle grafting. You have to go for. You have to debride the desmotocele thing, and you have to go for the carneal grafting. It is the only treatment protocol which we can go for the corneal perforation. But even after application of the this pedicle grafts, you will appreciate a white color after complete healing, a white color dot at the particular position because of that particular graft. But the condition after application of this proper application of this pedicle graft will not progress the desmotocele. Or you can use the autografts, there's a conjunctival pedicle grafts, or in commercial aspects, there will be collagen grafts are there. You can directly apply that.
సార్ జనరల్ గా ఈ షెడ్యూల్స్ లో మెయిన్ గా ఎక్కువ ఇష్యూస్ వస్తుంటాయి కదా సార్ జనరల్ గా.
Yes, yes.
కొంచెం
So
బేసిక్ ప్రోటోకాల్ ఏమైనా చెప్పండి సార్.
So the basic protocols are nothing will be
Protocol,
there.
topical.
Always first the hair on the face should not be there. So generally, if you see a Shih Tzu puppy which are presented to us, generally it will cover the head and the eyes, even the eyes. First of all, it should not be there. The hair clipping is must and very much required. Otherwise, we can't do anything for those conditions. The second thing, after observing the corneal perforation, if you are able to go for a temporary torsorrhaphy, go for temporary torsorrhaphy. After staining and after confirmation, if it is a superficial corneal ulcer, as I said earlier, you can go for the temporary torsorrhaphy and keep it for 10 to 12 days and remove it. While under temporary torsorrhaphy, you have to use the antibiotic drops also, both systematically as well as topically. So most of the superficial ulcers will be cured by this temporary torsorrhaphy and the antibiotic topical as well as the parenteral eye drops. Whereas in case of the deep ulcers, where you need to go for the grafting, pedicle grafting, autografts or the allografts, there is no other choice.
I think with this we can conclude the session, Dr. Mahesh. If any participants having any question, we just posted his number in the chat. You please copy his number and can DM him directly whenever he is free. So, okay, with this we are concluding this thing. So on behalf of APPA, we thank Dr. Mahesh for this wonderful lecture.